Today, you'll find out why your hair stops growing after 60 and why it has nothing to do with hormones or nutrients. A 2016 standardized clinical trial conducted at Toho University in Japan measured hair shaft thickness in participants before and after a single intervention, 4 minutes of mechanical scalp massage applied daily for 24 weeks. At the end of the study period, hair shaft thickness had increased significantly in all participants. No supplements, no hormonal intervention, no topical treatments. The only variable was 4 minutes of pressure applied in a specific way every day. Today we are going to explain the mechanism behind why that works and why it targets a cause of hair thinning after 60 that most content on this topic completely ignores. Hi, I'm Suki Yamamoto, wellness specialist.
And I'm Marcus Reid, your senior health coach. No fads, no miracle claims. Just what the research actually shows and what it looks like in practice. Let's jump into the studio. If you have been watching this channel for a while, you know we have covered two of the major mechanisms behind hair thinning after 60. We have covered the hormonal pathway, how DHT causes follicle miniaturization, and we have covered the nutritional pathway, how deficiencies in ferritin, D3, and zinc starve follicles of the building blocks they need to produce hair. And yet there are women who have addressed both of those things, who have had blood panels done, corrected their nutrient levels, and still are not seeing the hair thickness they expected to see. This episode is for them. Because there is a third mechanism. It does not involve your hormone levels. It does not involve what you are eating. It involves the physical environment of your scalp itself. And the evidence suggests that for a significant number of women over 60, this is the rate-limiting factor that the hormonal and nutritional fixes cannot reach.
What we are covering today is scalp fibrosis, the progressive structural change that occurs in scalp tissue with age, and the specific mechanical intervention with clinical evidence for reversing it. By the end of this, you will understand three things: what scalp fibrosis is and how it blocks hair growth independently of hormones and nutrients, the specific cellular mechanism that makes scalp massage more than a circulation improvement, and the exact protocol, timing, pressure, duration, technique that the evidence actually supports. We are going to be specific. Vague recommendations do not help you.
Let's start with what scalp fibrosis actually is, because I think most people have never heard this term in the context of hair loss.
Fibrosis broadly refers to the thickening and scarring of connective tissue, the accumulation of excess collagen matrix in a tissue that reduces its pliability and vascular supply. Most people associate fibrosis with organs, liver fibrosis, pulmonary fibrosis, but the same process occurs in scalp tissue, and the research suggests it plays a more significant role in age-related hair thinning than is generally recognized.
What drives it in the scalp specifically?
Several converging factors. The first is a signaling molecule called TGF-beta1, transforming growth factor beta-1. TGF-beta1 is produced in the scalp in response to both androgenic hormones and general inflammatory signals. It promotes the conversion of normal fibroblasts, the connective tissue maintenance cells, into myofibroblasts, which are contractile cells that deposit dense collagen matrix. Over time, this creates a fibrous layer beneath the scalp surface that is less vascular, less oxygenated, and physically less compliant.
So the scalp literally gets stiffer.
That is an accurate description. There is a clinical observation that has been noted by dermatologists for decades and more formally studied in the last 20 years, that areas of the scalp with the highest degree of thinning tend to have the lowest scalp mobility. A healthy scalp moves relatively freely over the skull when pushed laterally. A fibrotic scalp is tight, resistant to movement, and frequently warm to the touch, the warmth indicating an inflammatory microenvironment, even in the absence of visible skin changes.
And a scalp that does not move well. What does that mean for the follicles underneath it?
The follicle sits in the dermis, the middle layer of the scalp. Its blood supply comes from a dense network of capillaries that runs through the connective tissue surrounding it. When that connective tissue becomes fibrotic, denser, less pliable, capillary density decreases. The vascular network that delivers oxygen, nutrients, and hormones to the follicle becomes compromised. The follicle is sitting in tissue that can no longer adequately supply it, regardless of what is circulating in the bloodstream.
So this is why someone can optimize their ferritin and still not see results. The ferritin is in the blood, but if the blood cannot get to the follicle
cannot access it. The nutrient is present systemically. The delivery pathway is compromised locally. It is the same principle as having a healthy heart, but partially blocked coronary arteries. The supply is not the problem. The infrastructure is.
That is the piece that makes everything else make sense. People are not failing at hair health because they have not found the right supplement. Some of them are failing because the physical environment of the follicle has been progressively cut off.
That is the hypothesis the scalp fibrosis research supports, and I want to be precise about what we know and what we do not. The relationship between scalp fibrosis and hair thinning is well documented in histological studies. Biopsies of thinning scalp tissue consistently show fibrotic changes surrounding affected follicles. What is less established is the precise causal weight. How much of the thinning is driven by fibrosis versus hormonal miniaturization versus nutritional deficiency. These mechanisms coexist, and they likely compound each other. What we can say is that addressing fibrosis through mechanical intervention produces measurable outcomes, and that the Koyama study is the most direct evidence we have for the specific pathway.
Before we go further, I want to ask about something I have seen mentioned in discussions about thinning scalp. There is a compound called prostaglandin D2 that apparently is elevated in areas of hair loss. Is that part of this picture?
It is adjacent. A 2012 study by Garza and colleagues published in Science Translational Medicine found that prostaglandin D2, PGD2, was significantly elevated in biopsied tissue from bald scalp compared to adjacent hair-bearing scalp in men with pattern baldness. PGD2 inhibits hair follicle growth through a specific receptor. It is part of the inflammatory microenvironment of fibrotic scalp tissue. Elevated PGD2 is one of the downstream consequences of the structural changes we described. The relevance to mechanical intervention is that reducing the fibrotic and inflammatory microenvironment appears to reduce PGD2 exposure at the follicle over time. But I want to be careful. The PGD2 research has been conducted primarily in male androgenetic alopecia. Direct application to postmenopausal female hair thinning requires extrapolation that the evidence does not yet fully support.
So we are citing it as context, not as direct mechanism evidence for women over 60.
Correct. The Koyama Mechanotransduction data is the direct evidence. The PGD2 pathway is supportive context. It helps explain why the fibrotic microenvironment is hostile to follicle activity at a cellular level. That nuance matters.
So I want to try to explain the mechanism behind why massage works, because I think I understand it, and I suspect I might have it slightly wrong. The way I understand it, you massage the scalp, blood flow increases, more nutrients reach the follicle performs better. That is the mechanism.
That is part of it. But it is not the primary mechanism documented in the Koyama study, and the distinction matters because it changes how you think about the technique.
All right, what did I miss?
The primary documented mechanism is mechanotransduction. Let me explain what that means. Dermal papilla cells are specialized cells that sit at the base of each hair follicle. They are the master regulators of follicle behavior. They communicate with the follicle stem cells in the hair bulge region to signal whether the follicle is in the growth phase, the rest phase, or the shedding phase. They produce signaling molecules, including insulin-like growth factor 1, or IGF-1, and vascular endothelial growth factor, or VEGF, that directly control follicle activity and local vascularization. When dermal papilla cells are functioning well, the follicle grows. When they are suppressed by DHT, by the hypoxia from reduced blood flow, by the inflammatory microenvironment of fibrotic tissue, the follicle miniaturizes and eventually stops producing visible hair.
So the dermal papilla cell is essentially the on-off switch for hair growth.
It is more of a dimmer switch than an on-off switch, but that captures the function. Now, what the Koyama study found, and what subsequent cell culture research has confirmed, is that dermal papilla cells contain stretch-sensitive ion channels. When the tissue surrounding them is mechanically deformed by pressure, by stretching, by the movement of scalp tissue over the skull, these channels activate. The cell responds to the physical force as a signal. Gene expression changes. The cell begins producing more IGF-1, more VEGF, growth factors that directly stimulate follicle activity and vascularization, independently of what hormones are present systemically and independently of what nutrients are circulating in the bloodstream.
So the massage is not just improving the delivery of nutrients. It is telling the cells to start growing as a direct response to the physical force.
The mechanical force is itself a signaling event. The improved blood flow is a secondary benefit, real but secondary. The primary mechanism is the dermal papilla cells responding to stretch by upregulating the growth factors that drive follicle activity. That distinction changes the technique significantly.
How so?
If the mechanism were purely circulatory, then any gentle scalp stimulation, light fingertip stroking, a soft brush, would produce a meaningful effect. But mechanotransduction requires sufficient mechanical force to deform the tissue and activate the stretch receptors. The Koyama study used a standardized device that applied firm, consistent pressure. The key is moving the scalp tissue over the skull, creating actual mechanical deformation in the deeper tissue layers, not simply sliding fingers across the surface of the hair.
So light fingertip tapping is not going to do it?
Light stimulation may produce some circulatory benefit. It is unlikely to produce the mechanotransduction stimulus. The technique matters, and we will go through it precisely in a few minutes.
I want to make sure I understand the full picture before we get to the protocol. If fibrosis is reducing the vascular supply and the dermal papilla cells are also being suppressed by that hypoxic environment, are these two separate problems happening simultaneously, or is one driving the other?
They are a compounding cycle. The fibrotic tissue reduces capillary density, less oxygen reaches the dermal papilla cells. Hypoxic dermal papilla cells upregulate TGF-beta-1 as a stress response. TGF-beta-1 promotes further fibrosis. The follicle environment worsens progressively, and because the dermal papilla cells in a hypoxic fibrotic environment are also being suppressed in their IGF-1 and VEGF production, the follicle loses both the structural blood supply and the cellular signaling that drives its activity. The mechanical intervention interrupts this cycle at 2 points. It physically mobilizes the connective tissue, and it directly stimulates the dermal papilla cells through stretch. Both mechanisms matter.
Let's address the question that I think a lot of viewers are going to have. If they have been watching this channel, they may have had the blood panel from the ferritin episode done. They may have been taking vitamin D, zinc, possibly saw palmetto from the DHT episode, and they are not seeing what they hope to see. Is scalp fibrosis likely to be the explanation?
It is a plausible contributor, and it is the intervention most likely to be missing from their current approach. I want to be honest about what the evidence allows us to say. We do not have a large randomized trial that takes women over 60 with confirmed nutrient sufficiency and DHT management, and then adds mechanical scalp massage to measure whether outcomes improve above that baseline. That study has not been done. What we have is strong mechanistic evidence that dermal papilla cells respond to mechanical stimulation, A well-designed small trial showing that the specific protocol produces measurable outcomes, and the clinical logic that if follicle delivery is compromised by a fibrotic scalp, addressing nutrients systemically without addressing the local environment is incomplete.
So the recommendation is not to replace what they are doing. It is to add this.
Precisely. This is not instead of ferritin correction or vitamin D optimization. Those remain important. This addresses a different layer of the same problem. A woman who has her ferritin above 70, her vitamin D above 50 nanomoles per liter, and who is managing her DHT exposure, but who has not addressed scalp tissue health, may be missing the local delivery mechanism. The massage protocol costs nothing, requires 4 minutes a day, carries no side effects, and has direct clinical evidence for the outcome we care about: hair shaft thickness. There is no good reason not to add it.
What about topical products? Oils, serums, scalp treatments? Where do those fit?
The evidence for most topical hair growth products is either weak, industry-funded, or both. I want to be direct about that. There are two topical approaches with meaningful evidence. The first is minoxidil, which works through a VEGF-related vasodilation pathway that is genuinely relevant to follicle blood supply. The second is rosemary oil. A 2015 comparative study by Panahi and colleagues published in SkinMed found that rosemary oil produced equivalent results to 2% minoxidil at 6 months, with less scalp itching. The proposed mechanism involves inhibition of 5-alpha reductase and anti-inflammatory effects in scalp tissue. Whether topical products are used is a conversation for the individual and, in some cases, a dermatologist. What we are covering today is the mechanical intervention, which has a distinct mechanism, distinct evidence, and is accessible to everyone regardless of what topical approach they are or are not using.
Let's go through the protocol in the detail that people can actually use, because the difference between 4 minutes that work and 4 minutes that do not is entirely in the technique.
There are 4 elements: hand position, pressure level, movement type, and zone coverage. I am going to go through each specifically.
Hand position first.
Fingertips, not fingernails, not the palm, not a brush. The pads of all 10 fingers, place them flat against the scalp with moderate to firm pressure, firm enough that when you press down, you feel the scalp compress slightly toward the skull. Your fingers stay in contact with the scalp surface throughout the movement. You are not gliding across the hair. You are maintaining consistent contact with the scalp beneath it.
So the fingers are not moving through the hair.
They should not be. The target is the scalp tissue, not the hair shafts. If your fingers are sliding freely through your hair, you are not generating sufficient contact with the scalp. Part the hair if necessary to ensure direct fingertip to scalp contact.
Pressure next.
This is the most common error people make. The pressure must be sufficient to move the scalp tissue over the underlying skull, not merely stimulate the surface of the skin. A useful test. When you apply pressure and begin moving your fingers, the scalp should move with them. You should feel, and you can see in a mirror, the scalp shifting slightly under the pressure. If only the skin is moving, while the deeper tissue stays still, the pressure is insufficient to generate the Mechanotransduction stimulus.
That is a higher level of pressure than most people would instinctively use.
Considerably higher than a relaxation massage. This is a clinical stimulus, not a comfort intervention. It should not be painful, but it should feel like work. If it feels indistinguishable from gently petting your own head, it is not sufficient.
Movement type.
Small circular movements, approximately 2 to 3 centimeters in diameter, moving the scalp tissue in rotation over the skull beneath. The Koyama standardized device used a rotational motion at a specific pressure. Finger replication of this involves planting the fingertips firmly and rotating from the wrist, so the fingers carry the scalp with them through the circular movement rather than sliding across it. The movement is in the scalp. not in the fingers.
Zone coverage. How do you divide the 4 minutes across the scalp?
4 zones, approximately 30 seconds each, both hands working simultaneously where the anatomy allows. Zone 1, the crown, both hands working the top of the head from the crown point outward. Zone 2, the frontal hairline, both hands working from the midline outward toward the temples along the front hairline. Zone 3, the temples, one hand per side, working in small circles at the hairline recession points, where follicle miniaturization tends to begin first in women. Zone 4, the parietal ridge, the band running across the top of the head from ear to ear, which has high follicle density and is often under-addressed.
So 4 zones, 30 seconds each. That is 2 minutes. Then a second pass?
A second pass through the same 4 zones, or a longer first pass if certain areas feel particularly tight or immobile. The total active time is 4 to 5 minutes. The important thing is maintaining consistent pressure and rotational movement throughout, not reducing pressure to comfort as you go.
Timing. Does it matter when in the day?
The Koyama study did not specify time of day. The practical recommendation based on the mechanism is to perform the massage on a dry scalp before shampooing. After the massage, when you shampoo, the increased local blood flow and any loosening of fibrotic tissue occurs in a clean scalp environment. Some practitioners recommend applying a small amount of rosemary oil to the scalp before massaging, combining the mechanical stimulus with the topical anti-inflammatory effect. But this is practitioner protocol rather than the direct Koyama methodology. The oil is optional, the technique is not.
What about microneedling? Because I know some viewers will have heard of derma rolling for hair growth.
The mechanism overlaps significantly with what we are describing. A 2013 randomized controlled trial by Durat and colleagues published in the Journal of Cutaneous and Aesthetic Surgery randomized 100 men with androgenetic alopecia to either weekly microneedling plus minoxidil or minoxidil alone. The microneedling group showed 4.5 times more hair count at 12 weeks compared to minoxidil alone. The proposed mechanism is wounding-induced growth factor release. The micro-injuries trigger a healing response that includes IGF-1 and VEGF upregulation by dermal papilla cells. Mechanistically, it is the same growth factor cascade as massage, through a different physical stimulus.
So microneedling is a more aggressive version of the same underlying mechanism.
Mechanistically, yes. It involves a 1.5 millimeter derma roller applied weekly, which requires either a practitioner visit or careful self-administration with proper sterilization. For women over 60 on anticoagulant medications or with active scalp conditions, it is something to discuss with a physician before attempting. The massage protocol is the appropriate entry point. 0 risk, 0 cost, direct evidence. Microneedling is an escalation option for those who have already built the consistent massage habit and want to go further, not the starting point.
Let's talk honestly about the timeline. Someone starts this today. What do they see and when?
The Koyama timeline was 24 weeks for measured objective increases in hair shaft thickness. I want to be direct about that. 6 months of daily consistency is what the evidence supports. Some participants reported subjective changes earlier, reduced shedding, increased density perception, but the objective measurement at 6 months is what the data shows. The mechanism is slow because follicle growth cycles are slow. A follicle in the resting phase takes time to re-enter the growth phase. The 4-minute habit is not producing results in weeks. It is shifting the follicle environment, and follicle environments change on the scale of months.
4 minutes a day, 6 months. That is the commitment.
That is what the evidence supports. And consistency is the limiting factor, not the effort required. 4 minutes daily produces better outcomes than 20 minutes twice weekly. because the mechanical stimulus needs to be regular to maintain the cellular signaling response.
And for someone who does this consistently for 6 months and still does not see any change?
That is the conversation to take to a dermatologist who specializes in hair loss. There are medical conditions, lichen planopilaris, frontal fibrosing alopecia, where the fibrosis is severe, progressive, and involves an immune component that requires clinical management beyond lifestyle protocols. The presence of scalp itching, tenderness, redness, or visible recession at the frontal hairline are signs to pursue a dermatological evaluation before relying solely on self-administered approaches. We can explain the mechanism. We cannot substitute for a clinical assessment of what specific type of hair loss someone has.
And the self-assessment test you mentioned earlier, scalp mobility, is that a useful first indicator?
It is a useful first indicator, not a diagnostic tool. Press firmly on the scalp and try to move the tissue laterally over the skull. A mobile scalp moves noticeably with gentle lateral pressure. A fibrotic scalp resists movement or moves only minimally. If you feel very little give, particularly over the crown and frontal zones, that is consistent with the fibrotic pattern we have been describing, and it supports the case for prioritizing the mechanical intervention alongside whatever systemic approaches you are already using.
Let's bring it home. Today, we covered the third mechanism behind hair thinning after 60, one that has nothing to do with your hormone levels and nothing to do with what you are eating. Scalp fibrosis, the progressive hardening and reduced vascularization of scalp connective tissue that compromises the follicle environment at the local level independently of what is happening in the bloodstream. The 2016 Koyama study showed that 4 minutes of targeted daily mechanical stimulation, applied with sufficient pressure to activate dermal papilla cell mechanotransduction, produced measurable increases in hair shaft thickness across 24 weeks, not through improved nutrient delivery alone, through the cells themselves responding to physical force by producing the growth factors that drive follicle activity.
The protocol. The pads of all 10 fingers, firm pressure, small circular movements that move the scalp tissue over the skull. 4 zones: crown, frontal hairline, temples, parietal ridge, 30 seconds each per pass, repeated for a total of 4 to 5 minutes. On a dry scalp, before shampooing, every day. The timeline is 6 months for objective measurement. Consistency is the limiting factor.
3 mechanisms across 3 episodes: hormonal management, systemic nutrient correction, local scalp tissue health. The complete picture addresses all 3. No single approach reaches everything, but all 3 are within reach, and none of them require you to spend money on products that have not been independently tested.
The most useful first step, if you are experiencing ongoing thinning despite other interventions, check your scalp mobility. You now know what you are looking for, and you have a specific, evidence-based protocol to start with today.
If this was useful, the like button genuinely helps more people find it. Subscribe and turn on notifications so you don't miss next week.